Hello everybody, my name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Welcome to our webinar today. It's part of our series of keeping Aboriginal communities informed, and today is what happens if you get COVID. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we meet on today and pay respect to elders past, present and emerging. We have a fantastic lineup of presenters for you today. We have Christy Crooks, who's the Aboriginal Public Health Lead of the HNE COVID team. Julie Kohlhagen, the COVID Operations Co-Lead for the Hunter New England COVID team. Katy Barrett, Aboriginal Operations Lead, Hunter New England COVID team. Krista Smith and Vicky Brandy, who's Aboriginal health workers from the HNE Aboriginal Health Unit. Krista and Vicky are going to speak later on during the webinar, and their talk is about their time out at Wilkenya, which I'm really looking forward to hearing about. And the other ladies are going to start off first with an Aboriginal Epi update. So I'll just turn off my camera and share my screen and we'll get underway.
Thanks, Jenny. Yama, and thanks everyone for having me. I'm Christy Crooks, a Yarralari woman from Dubbo, and currently the Aboriginal Public Health Team Lead working on the COVID response. Before I begin the presentation today, I will acknowledge the lands of the Awabakal people where I'm presenting from today and pay my respects to elders past and present, and acknowledge all Aboriginal people who are online listening today. Next slide, please. So before I start, I just want to show you how quickly, again, how we at Hunter New England Local Health District is working a bit differently to all the other districts. So this slide here is what we call an incident command system, or an ICS structure. It's a military structure that helps us to organise how our health system works in a pandemic. Our public health controller, Dr. Dave Durheim, runs the response, and all of the public health staff are reorganised into teams and to respond to the surge. In Hunter New England Health, we have an additional arm in our ICS, and that's the Aboriginal Public Health Team, who provides cultural governance across the entire system. So at the very beginning, we wanted to provide cultural oversight over teams, but we soon learned that providing oversight wasn't enough and that we needed our own team to drive our own local response at the same level as the operations arms of the ICS. Our team currently is about 30-odd staff, which have all onboarded now, and it's grown since we started last year. And we are really grateful and thankful for everyone working with us while we navigate this challenging and evolving space. And across this landscape are hundreds of other staff and many moving parts. Next slide, please. But we have a shared belief that Aboriginal health is everybody's business, and we really wanted to provide every person in the Hunter New England Health District an opportunity for culturally appropriate care if they get COVID, which is what Kylie and Katie will talk to more about later. But to do this, we have to know which of our cases are Aboriginal. So we went about this and implemented accountability frameworks into every pillar across the ICS. So all the white boxes you see here are the actions taken by every team to ensure we're asking the question, identifying outbreaks as soon as possible, and flagging our Aboriginal governance group of any COVID risks as soon as possible. So these structures were fully informed and led by Aboriginal staff in the Aboriginal Public Health Team and our data governance structure. Next slide, please. And because we've used our Aboriginal governance structure to embed accountability frameworks throughout the entire Hunter New England Local Health District's incident command system, out of the 2,695 cases in the district today, we know the Aboriginal status of all but one of our cases. Today I checked the numbers and we see that we have 704 Aboriginal and Torres Strait Islander cases across the district. This understanding has triggered almost 2,000 cultural support referrals for cases and contacts, and 280 of these are actively being followed up. They're a mixture of Aboriginal contacts and cases where they receive regular phone calls by our Aboriginal staff and a set support packs if needed, which may include food boxes, phone credit, and personal care items. But Katie and Kylie will talk about this a little bit later. Next slide, please. In Hunter, New England, most Aboriginal people are getting COVID, abubs, young people and younger adults, and we've seen cases from age 0 to 88, and a few more males than females are catching the virus. So 30% of cases haven't had a vaccine, and that could be because they've haven't had a chance to get one, or they've been too young to be eligible for one. We've seen about 20% of cases are under the age of 12 years old, and this group can't get a vaccine. And almost 30% are aged between 12 to 25. So because you're eligible, it's really important to go and get the vaccine. Next slide, please. So when we're looking at this bar graph, the red bars mean that cases are infectious in the community for more than 1 day, and the amber bars are infectious in the community for 1 day. So cases have been visiting homes, shopping centres, going to school or childcares, and not knowing that they were a case, and some have had no symptoms and unknowingly spread the virus for up to a week. The green bars haven't been infectious in the community at all, which means that they are likely a household contact of someone and knew that they had to isolate. And the aim for slowing down COVID is to try and aim for the green cases. Next slide, please. So this is just an epidemic curve that shows all of our cases since the Delta strain. In the bottom row are the dates, and the numbers up on the side are number of cases, and each horizontal line jumps up by 20 people. Aboriginal and Torres Strait Islander people are in the red colours, and yellow are not Aboriginal. And we haven't been able to interview the green people yet to find their Aboriginal status. So when we're looking at the red colours, you can see that at the beginning we had very few Aboriginal people caught up in this outbreak, but cases have now gone from virtually 0 to being 1 in 4. So this means that the likelihood of you getting COVID or knowing someone who has it is much higher now than ever. Next slide, please. So how is COVID spreading in Aboriginal communities? We're seeing lots of transmission within and between households, and it's the most common way COVID is spreading across the district. You're seeing 7 out of 10 Aboriginal people are getting COVID from within the home. And the first case to an outbreak has usually been infected at work or school, and we're seeing lots of an increased trends in outbreaks occurring across workplaces and crisis accommodation. Next slide, please. So this is just a slice of an ongoing outbreak which started with someone going to work and getting infected by a colleague who actually came to work with symptoms. So this is how the outbreak spread across households over a 2-week period, and some of these households were in different towns. Most of the people were doing the right thing, and we know with Aboriginal families and our ways of living and being together, there was lots of kinship care and childcare arrangements in place with people living across multiple homes. Lots of this interaction was before there were restrictions in place and people were infectious without knowing it. It just shows how Delta is really infectious. So if one person gets it in the home, you can almost guarantee that everyone in the house will become positive. This is also why it's important to provide information about everyone you've been in contact with if you do become a case, because it helps us to make sure those people are isolating safely and not spreading it to others in the house. Next slide, please. So embedding cultural governance has freed up space for Aboriginal-led surveillance strategies to embed into the response. And one of these is an early warning system called COVID, Local and Cultural Intelligence. Through mapping households, we also understand that many towns and Aboriginal communities in the district are highly linked despite being great distances. And we've got here an example, Armidale and Kempsey, which is about 250 kilometres apart. So if we get an Aboriginal case in a specific town, our team, the Aboriginal Public Health team, uses local and cultural knowledge and intelligence, which enables us to stand up testing in linked towns and to let Aboriginal services know very early on. Next slide, please. Just to finish up, so Aboriginal people are a priority population for COVID, and the extra work we have done to embed cultural governance across the entire COVID response ensures that everybody working in Hunter New England Public Health Unit has a responsibility and accountability to prioritise Aboriginal people and communities. And some of the key public health measures that we are doing to prevent COVID is the vaccinations. Now, COVID vaccines are up to 95% effective and present our best chance of reducing transmission. And while the population has had a chance to become vaccinated, restrictions on people's movement and interactions are still in place. Contact tracing, where we're seeing isolation of cases until they're no longer infectious and quarantining any close contacts for 14 days after their exposure. And coordinating an outbreak response. So certain environments are unfortunately high risk for rapid transmission, and such as nursing homes and crisis accommodation. And these outbreaks require targeted public health support to prevent rapid transmission and high case numbers. And we're working really hard to minimise the number of people becoming infected or sick with COVID. I think that was it for me. Thanks, Jenny.
I'll keep going, Jenny.
Yes, please.
Okay. Hi, everyone. I'm Julie Kohlhagen. I am a co-lead in the operations part of the ICS structure that Christy presented earlier. I was born in the country, but now live in Newcastle. So born near a little town on the Victorian border called Walla Walla, which is Place of Many Rocks. So nice to see you all here today. We'll begin by just having a look at what actually happens when we get a confirmed COVID case and take you through the steps of the journey for that case and where we may transition out and other services transition in to continue the care for the case until they're released from isolation. So every case that's had a laboratory specimen confirmed comes through to each public health unit across New South Wales. Each public health unit is required under the Chief Health Officer's KPIs to be starting to attempt an interview with that case, and ideally within 4 hours of notification the interview should be completed. So that's in an ideal world. The team around the health service acknowledge that sometimes that can take us the course of an entire day to get through to someone, but with help from friends and families we usually get to someone within the day. That case interview can be as quick as 30 minutes or as long as 2 hours. And what we do is we risk assess every part of life for the case. So from what they're doing within a home to what they're doing outside of their home, who they're having contact with, for how long and how closely, and assessing who's vaccinated and who's unvaccinated, assessing large venues or high-risk venues and their occupation. So trying to identify where we have a risk of further transmission to high-risk groups. The way we do that is through determining onset of symptoms, and we use a calendar of life in the days prior to their onset of symptoms and acknowledging not everyone has symptoms, and where they don't have symptoms we go with the swab collection date. So once we've interviewed someone and they've shared life and the activities that they've done in the days prior to their onset, we then present that case to our public health physicians, to the cultural support team, and with the assistance of the planning team as well. And the reason we case conference someone is to work out ongoing needs for that person, the community that they live in, and looking at risk and impact of further cases for the area that the case resides in and the community that they live in. So once we've had that case conference and throughout the interview, we're constantly thinking about reducing the risk for that family and their close contacts. So whether that's finding alternate accommodation, needing to get those close contacts rapidly swabbed, moving people out of their home, but also linking them with services. And there's a whole range of services that are involved in support and care of a COVID case, and there's a few listed there in the little calendar timeline there. We've got COVID care in the home, which is the HNE Local Health District Service, previously known as, I guess people may have known, hospital in the home. Well, this is COVID care in the home, and they provide support for cases that are well enough to stay at home. There's also a new team called COVIS, and this team is drug and alcohol and mental health services that have joined to form this team to support cases at home or in health accommodation, to help them throughout the isolation and support them with what they may need during that period. Also AMSs, GPs, and of course hospitals if the person was admitted to hospital. So that we actually transition there out of the ongoing management of a case, and the services listed there continue to keep an eye out and support the case and their household through to release from isolation. So the release from isolation can take up to 14 days or more, depending how well the person does, and they're released from their isolation from the COVID care in the home, not from the public health unit. So some challenges within just that simple timeline. There's lots of things happening in people's lives, and then we throw in these independent things like sometimes we can get a false positive or an indeterminate result, and that means we need further testing, but we treat everyone as a case until we can undo that they may in fact be negative. There's a reluctance to isolate from some people. There is strict health accommodation criteria that people need to meet before they can be accepted into health accommodation, and flagging that the health accommodation is free and meals are provided there. And really only in metro that we have that health accommodation, so not so good for rural and remote, and certainly advocating, I think, each week for that for Hunter New England. And then we also have challenges in people having a cloudy recall or lack of trust with us and sharing exactly where they may have been or who they actually have seen, and that's the joy of having those other services involved in the support and care and recovery. Often we'll get more information afterwards. Some achievements that the team have certainly experienced over the last 18 months of the pandemic. We've surged from 10 staff to approximately 100 staff that are doing case and contact tracing, mainly case follow-up now. We've got a lot more streamlined processes and referral mechanisms. We're able to interview most of our HNE cases every day, and occasionally we do get assistance from the Ministry of Health to do our case interviews. Our preference here in HNE is to interview our cases, knowing we know district better than someone sitting in Sydney, and certainly we get a lot more stories than someone sitting in Sydney. And one of the funny little, I guess, experiences we've had, we've even sourced pet accommodation to make sure someone can isolate effectively and agree to being transferred to hotel accommodation. So next slide, thanks Jenny. This is a contact management, and certainly there's been something like 64 changes in the first 8 months of the case and contact management last year. I've lost track of how many more changes have occurred to case and contact management, and where, you know, the last week we've certainly had some changes according to vaccination status with contacts. So there are information sheets now loaded around contact management and what isolation means for vaccinated, partially vaccinated or unvaccinated people, and they're on the New South Wales Health website. So we collate a list of close contacts, and we do ask names and mobile home phone number, vaccination status. Then we will talk to close contacts in the household or even outside of the household and organise testing straight away here. And then others that may not be high risk are transferred to Ministry of Health for Ministry of Health follow-up. The Ministry of Health are doing phone calls and mobile messaging, which provides a plan of what's required for a contact while they're in isolation, and that'll include a testing regime. So they'll need a test as soon as they find out, then at day 6 and day 12. There's also the offer of alternate accommodation for close contacts as well. So they can move out of the house if it's easier for a close contact to move out of the house and the case remain in home. And the same situation for close contacts, it's free, the accommodation and meals are provided as well. COVID Care can also help close contacts support through isolation as well. So that's the drug and alcohol team and mental health services. And then the release from isolation, or for some, they'll become a case. So the real challenges we've had, Delta's so infectious that often contacts are already incubating the virus when we get to them. Contacts not shared during the interview are missed, and we may get details later that the case remembers, or we know there'll be some that end up not on our list. Delay in test results and a longer isolation period. So depending how many people in the community are, excuse me, getting tested, it can be a little delay before you can be released. You always need your negative before release. And then some confusion around people getting messages from people in Sydney versus messages from the local health districts. So the lovely achievements for the contact management that occurs is relationships with the support services, and knowing and supporting a family through isolation, and the joy that occurs when they don't become cases and they're actually released. Being able to provide people with information and helping them understand risk and helping them wade through decisions around if it's better for someone to move out or in, and work through that has been really a benefit for the team as well, seeing that they've helped risk assess a household with people and help them decide what might be best for the family. So just in a nutshell, close contacts isolate away from others. They need a test now. They need a test at day 6 and day 12. And then they keep isolating for the full 7-day period if they're fully vaccinated and their last vaccine's 14 days ago or more. Or if they're unvaccinated or partially vaccinated, they will still need to complete a 14-day period of isolation. Jenny, I think I'm done. Thank you.
Thanks, Julie. Katie, are you there?
Yes, I am. Yep. Yama, everyone. My name's Katy Barrett. I am a Gomeroi woman. I'm also a registered nurse, and I am the Aboriginal operations lead. So that means that I oversee the cultural support process at Public Health. Now, this slide here is our overall process. So we've got step 1 to 5, which includes, step 1 is the case interview and case discussion. Step 2 is the referral. Step 3 is the allocation. Step 4 is the cultural support. And step 5 is the end of isolation and review. And I will go over this process in depth in the next slides. Next slide, please. So step 1 is the case interview, which Julie just covered. So this is the operations team and the case interviewers. The public health nurse conducts an interview with the case and contact using the PHU case contact interview form. The case and contact identifies as Aboriginal or Torres Strait Islander within that interview, and a case conference is then held with the cultural support team leads. Step 2 is the public health nurse sends an email to Aboriginal cultural support leads with case contact details requesting cultural support for the individual. Sometimes within the case discussion as well, we do sit on the case discussion and take some of that intel from the information that was passed on to the interviewers into our referral besides the notes as well. Next slide, please. So step 3, Aboriginal cultural support leads actions, referral for local support and follow-up. So Aboriginal cultural support leads review the case and contact details and provide additional cultural intelligence, clinical intelligence and relevant information from the case conference. This is generally my role. We do have some new staff coming on as well, but this has, primarily been my role for this response in the surge. And that, me sitting as a registered nurse, I have that clinical intelligence. I also have the ability to have the cultural intelligence and community knowledge to combine them all together and then inform the complexity of the case, I guess, for follow-up cultural support. The Aboriginal cultural support reviews the case and contact interview notes from the nurse as well as from the case discussion. The cultural support leads and conducts the initial cultural support phone interview to the case if it is urgent or complex, or urgent supports are identified. Otherwise, the referral is passed on to one of our Aboriginal cultural support officers. Case and contact is then allocated to appropriate Aboriginal cultural support officer to provide ongoing holistic health, wellbeing and cultural care that addresses access barriers. The allocation is determined off, we have cultural support officers that sit all over the district. So depending on where the case or the contact is located, we usually try and allocate them to someone that is local to where the case is. So they know most of the local supports that they can link them in with. Otherwise, we do have a mapping spreadsheet that they can also go off where we have a list of all the services to connect people with. Now, if it is a case or a contact that is a child, obviously the phone interview is conducted with the parent or the guardian. Next slide, please. Step 4. This is Aboriginal cultural support, team member actions, referral and follow-up. So this is where the Aboriginal cultural support telephone officers make contact with the case or contact. So they offer the cultural support in the first instance and people have the option to decline cultural support or take up the cultural support, essentially. There is an interview form that the cultural support officers go through. They go through quite a comprehensive interview with people just to determine any other supports that may not have been identified within the case interview. We know that, the initial case interview, people are quite anxious. They've just received the news that they may be COVID positive or they've become a close contact, Sometimes they forget their information. Sometimes they're just not very forthcoming with their information. And I think that's why we have this cultural support process where we can sort of jump in and make that connection and people feel comfortable to tell us a little bit more about their situation and what supports they may need. The cultural support officers, then they record all the details of their phone calls. They may call, depending on the person and what support they would like. Their support is determined by them really. It could be daily, it could be second daily, third daily. We sort of leave that up to the discretion of the case or the contact, how much support they would like. Now this is all recorded on our OneNote form, on our interview form, and then the notes essentially are reviewed by myself or one of the other leads, and the cultural support officers escalate anything that is concerning back to us. If there is anything concerning to myself that I think that I sort of can't address, then it is escalated higher, probably back to operations, so Julie's team, for assessment. Step 5 is really just the review. So this is when they've reached the end of their isolation period. They're ready to come out. We just touch base with them. The public health team, the operations team let us know when they're coming out of isolation. And then we wrap it up and touch base with them and sort of get a review and a survey of how they've found the cultural support process and whether they were happy with our services. Next slide. I think this might be Kylie's slide.
Yep, thanks, Katie. Hi, my name's Kylie Taylor. I'm an Aboriginal health worker, and at the moment my role in the COVID team is the Community and Services Engagement Lead, and I also want to acknowledge the lands where I'm joining in from today of the Gomeroi people, and also extend a warm welcome to everybody, and pay respects to wherever you're joining in from today as well. So once Katie has finished doing her very comprehensive assessment of each case or contacts that comes through to our team, and once the Aboriginal Health Unit staff and our staff who are now undertaking most of those phone calls, once they've come back to us with any supports that are identified, it's my role to then work with our internal team, so our Julie's team, our public health physicians, our planning team, and our logistics team, to ensure that we can provide all the supports that were identified. We also work with our external partners and key stakeholders. We work very closely with all of the AMSs right across HNE. That has been really the strength in this whole response, has been that relationship and partnership with the AMSs. To date, they've been providing a lot of that cultural support to their clients, as well as the vaccine rollout. So so once we find out what everybody needs, it's a real partnership approach to ensure that we can connect people with some food boxes. That's either through Resilience, Department of Aboriginal Affairs, or the state land councils, and those partnerships that we have there. We also are working with the local land councils and the local emergency management committees to enact the community action plans for the discrete communities. So they have their own plans about what will happen if they get a COVID positive case in their community, and that's working with them and the district to increase testing, whether that's door-to-door testing, pop-up testing, drive-through testing, and really making sure that testing is accessible to all of our community members. Because it's not the same, as Julie said, in the metro regions as it is out in the country and out in the rural and regional and remote communities. We really need to work together to ensure that there's that same equitable access as there is that it's right across the district. So also look at getting people phone credit if they need that, so they can stay in touch with us if they need to ask any questions or they need any extra support. But it's also so they can maintain connection to their family members as well. We know Aboriginal people are very closely connected, and as Julie identified, putting people in isolation for a couple of weeks can it can really it can really make people increase their anxiety and loneliness, and we want to make sure that people can stay connected. We also like to connect people with a GP. Your GP doesn't automatically find out that you do have COVID unless that's where you got your test at. So if you've gone through a drive-through or a pop-up, your GP doesn't automatically get notified. So with Aboriginal people and underlying medical conditions and other, living with poorer health, we sometimes, really want to make sure that Aboriginal people are connecting with their GP. That way, there's that ongoing clinical care that's needed if people do have, lingering COVID symptoms or other symptoms, and especially afterwards, if they haven't had a vaccine, which is what we're finding for a lot of our mob at the moment, when they get COVID's finding the unvaccinated, is we're ensuring that we're linking them up with a vaccine afterwards and transport if needed. So whether it's, having the AMSs or somebody come out to them if they don't have transport, really trying to hook everybody up with a vaccine now. There's plenty of vaccine available, but it's about those identifying those vaccine opportunities for people and working with them to get one. Also trying to ensure our mob have access to any COVID payments, the test and isolate payment, and linking them in with the Service New South Wales COVID isolation supports that are available as well. A lot of people don't know about these things, so it's really ensuring that people are aware, and again that they're offered the same as everybody else. At home testing, as I just mentioned, a lot of the mob don't drive or don't have testing in the towns that they live, or testing sort of that's needed. completed. So it's really working with the district to ensure that, yeah, that testing is accessible, especially given that our vaccination rates are still lower. So really making sure that people have the opportunity to get a COVID test if they need to, and they don't have to drive sort of to the nearest regional centre for that. The information sign there, you know, it's about making sense of all the public health orders. As Julie said, there's been many changes. Even for us, every day there's a change in process, a change in fact sheet, a change in all the rules. I'm sure you're all over that as well. So when we talk to cases and contacts, it's, you know, having that time to explain all of those, all that advice and their actions, and how that makes sense to them and their families. You know, and working with the families to ensure that they can maintain safe isolation, and, you know, because they really are doing us a favour in public health by staying home and isolating, because that's reducing the spread into our communities. So our team, you know, wants to ensure that they have the tools and the resources and what's needed to stay home safe during that time. And then lately, of course, now that it's spreading amongst our Aboriginal communities, Aboriginal people use Aboriginal organisations. I think over a weekend here in Tamworth, the Youthie got taken out, TAMS got taken out, Wall Health got taken out, and the Aboriginal Hostel got taken out. So working with each of those organisations and helping them go through their risk matrix, their venue risk assessments, because, you know, we do have much higher rates now in HNE, so that is also going to disproportionately affect the Aboriginal organisations in our communities who support Aboriginal people. You know, so really making sure that we're working with all of our Aboriginal community controlled organisations, yeah, and providing that advice to them as we need to. So you'll see this is why it's really important that we identify straight up, are you Aboriginal? Because then all of this service and support, you know, can be activated for Aboriginal people right across HNE. If we don't ask that question and we don't, you know, actively ask the question and try and find Aboriginal people who are impacted by COVID, that they miss out on, you know, on all this extra culturally appropriate care and support that they can be receiving. And we know now with the pullback in contact tracing by New South Wales Health and by the districts, that it's going to be really hard to find some of those close contacts, but our team will endeavour to find every close contact and you know, and try and still support those people. So if you do hear of any who haven't had any contact from health at all, and especially from our cultural support team, then please reach out. And we couldn't do all of this work without the ongoing support of our real partners in this, which is Tony Martin's team at the Aboriginal Health Unit. They've been key partners from the start in all this, and as Christy and Katie said, they've got the local connections and they know the local supports, and so we want to really say thank you to that team for you know, for doing what you guys are doing, because we yeah, we couldn't do it without you. That's the end of my slide. Thanks.
Thanks, Kylie. Krista and Vicky, are you there?
We're here.
Yes, Jen.
Vic, did you want me to start?
Yeah, thanks, Krista.
Yep. So firstly, before I start our experience working out at Wilcannia, I just want to say and acknowledge and recognise the other staff members that came out on this journey with myself and Vicky. I just want to acknowledge Leonie Garvey and Mandy Cutmore. So we're out there for a total of 33 days in Wilcannia. And we kind of didn't know what to expect, or, you know, going out to a community that we haven't worked. So I just want to recognise the other staff members that went out to Wilcannia and worked, and yeah, just recognise all the commitment and time for working out there for the whole month. Next slide, Jen. So firstly, before we get into the presentation, I just want to acknowledge country. We're all meeting on Aboriginal land today and pay my respect to elders past, present and emerging. I'd also like to acknowledge the Barkindji mob and community. for allowing myself, Vicky, Mandy and Leonie to work and travel through their community, and also acknowledge all Aboriginal staff that's on this webinar. Next slide, Jen. So just a bit of background on Hospital in the Home. So Hospital in the Home is a clinical care model that reduces the length of stay in hospital. It's also a model care to provide health care within the home. It also allows it also identifies better patient care and the remain comfort within the home. It's more accessible and it's more eliminates families and clients to manage and organise transport to appointments, whether it's in the hospital or at community health, and it can also avoid hospital admission altogether. Next slide. So just a bit of background with the Hospital in the Home out at Wilkenya. So what did the team consist of? It was 3 staff members that conducted the home visits daily. So there was 1 mental health worker, which was either they worked in drug and alcohol or sexual assault and domestic violence. So when we were going out there, they had that background and expertise. There was 1 registered nurse and also 1 Aboriginal health worker. And the feedback that we got from conducting those home visits with the clinical staff, that it was very vital to have Aboriginal health workers there. The feedback we got back from them daily that, you know, we couldn't conduct those home visits going out to Wilkenya, us having, you know, experience working in community and also having that cultural understanding with Aboriginal people and families. Next slide. So this is just a bit of a background and just to show you guys when we were going out to do the home visits, and the home visits could be anywhere between 10 and up, so 10 households, could be up to 30 to 40 households a day. And this car was the car that conducted the home visits. So when we'd go out, there would be 3 of us in the car, and in the back of the boot was the contaminant or dirty area, like you call it. And in the back passenger seat is where all our PPE was. So we would travel around in Wilkenya to conduct the home visits daily. Next slide, Jen. So this is just a bit of an indication and background on what we did daily and performed prior to conducting home visits. So before actually going in and seeing the clients and family, it would take us pretty much 5 to 10 minutes pre and post before going into the client and the household. So this was extremely challenging, you know, being out in remote, hot weather, doing this every time before you actually go in and see a client. So it would be Dauphin and Domin every day. Before we actually got out in the field and done any home visits, we had training done by a nurse educator, which gave us the training on how to PP up daily and how to dom and doff. So before we actually went out and done all that, we'd had just a bit of an introduction on how to do that. So no infection control measures were breached. And yeah, that could take up to 10 minutes before you go into the actual household. Next slide. So what was conducted at the home visit? So a bit of observations, which was taking clients and families' pulse rate and oxygen levels, recording COVID symptoms, and, you know, the nurse was there to provide that medical advice to manage symptoms at home or when they were isolating. So it was just a more around how to manage it. Cultural support, social and wellbeing yarning, so yarning with the clients. Mental health assessments were also conducted, coordinating accommodation and transport. Because we did have mental health clinicians there, we had, they, you know, had that expertise in violence and domestic violence as well as sexual assault. So, you know, there was also that carried out on the home visits, delivering food and household essentials to home and making referrals to key stakeholders. and it was really challenging too to go out every day because myself and the other clinicians within the team didn't actually have that relationship. So it took a good 2 weeks to build that rapport with community, and then by the end of it, it was really rewarding and also good to see that community members there was hardly anyone that really got sick. Next slide, please. So this is just to kind of give you an idea on where all confirmed cases, the accommodation was. So it was Warrawong, and, you know, we did think, like, you know, it wasn't family friendly, so it was always at capacity. They only had 2 family rooms. So you can imagine that if you've got a mob of, you know, more than 4 or 5 people, it was extremely hard to fit into these little single rooms. So at the actually caravan, well, Warrawong, it was only 2 cabins that could accommodate for Aboriginal families. And Vicky can talk more later about the vans and such, but this was just a bit of a screenshot on where all the confirmed cases was. So would go out daily and conduct the home visits. Next slide, please, Jen. So just some challenges throughout the home visits. So working in remote, you were unable to find the addresses. So there was no mailboxes or numbers on the households. And this was due to lack of repairs and maintenance to homes. So when we'd go out, a lot of community members would say, you know, the houses weren't built or they weren't culturally appropriate, and this wasn't done initially. So there was no community consultation or any ongoing repairs to the homes. Overcrowded houses and families, and advising, you know, they were unable to isolate safely. Some clients frequently changing addresses. So they would move house to house and then would be able to have to drive around and be able to still locate the clients to perform the hospital in the home and patient care to the client. Also, we found a lot of houses didn't have any aircon or fans or heating. So yeah, there was no heating in the houses at all. And also we found that a lot of community members that were in Wilkenya actually came down initially for a family funeral and were stuck in Wilkenya for, you know, it could be up to 8 weeks. But Vicky's going to talk more about that, about sorry business. Next slide, please. So just some major health concerns. So just a screenshot, mental health, domestic violence, sexual assault, chronic diseases, drugs and alcohol, overcrowded houses, lack of services, so like dentists, NDIS support, lack of access to nutrition and household essentials, and also very expensive for living. So IGA was the only local grocery store, and a loaf of bread could cost up to $8. So it was extremely hard for community to be able to carry out, you know, eating healthy and stuff when there was just no access or resources in the community. Next slide, please. So this is just kind of a snapshot of the cases in Wilkenya. So the first case reported was the 18th of August, and then as of the 15th of September, there was 130 in Wilkenya, and then the 22nd of September, there was 145, and as of the 4th of October, there was 152 cases in Wilkenya. And we'll talk more about that later when we get to the next few slides. Vic, did you just want to jump in now and talk about the community support accommodation?
Yep, sure, Krista. Hi,
Thanks,
everyone.
Vic.
I just firstly want to acknowledge the Gomeroi people on the lands that I'm presenting from today. As a Wiradjuri person, it's important for me to acknowledge local country out of respect. For us, you know, going out to the outback to work, it was actually a lot of unknown uncertainties and knowing what we're going to go into. But I think the biggest strength for us was that we're actually Aboriginal people from community, myself coming from the mission, Krista coming from Camp C. We had strong connections. Yeah, so basically Krista and Leonie and Mandy were put in the in community. I was out with the supported accommodation of close contacts, where we had 34 camper vans at the Victoria Caravan Park, which arrived on the 4th of September. For me, working on the ground level and in Wilcannia community highlighted a lot of risk in that the first one being identified was that the elders were not consulted about the arrangements within the supported accommodation. The CE was there at the time, and it was an opportunity for the CE to actually have face-to-face conversations with the elders to inform them exactly of how the families were going to be catered for, and especially the larger families. So as you can see from this picture, there were fences that were dividing and separating the vans. So we were notified that we had the one family coming through, and they basically had a number up to 15 people within the families. That was originally went out there, as Krista mentioned before, for a family funeral back in July, got stuck there because of the outbreak, and then one of the cases became positive and ended up in hospital. So, and which the rest of the family were actually were told to isolate in the motel, 2 rooms, 15 people, very overcrowded, as you can imagine. So they actually came through to the supported accommodation at the caravan park on the Wednesday. First couple, we had a young bub. She was 5.5 months old. She was in the care of the grandmother and the aunt. Just, you know, working on the ground level is actually presented, it was very complex in saying, you know, we had to be aware of and work within all the social determinants of health, looking at, you know, food security, accessing their own medical records back within their own community, because the families that I supported at the site was actually, they were from out of town, as I said, and was actually getting access to their own health records and building up their trust as well. So, you know, also there was a lot of community politics within the community itself in accessing resources and supplies, which was really difficult. Because I was located down at the supported accommodation, New South Wales, the supported accommodation was actually New South Wales' responsibility. Therefore, they were to provide the care and also the resources for the families, and which possessed a lot of issues, because we had prepackaged food, 3 meals three times a day, but it actually didn't really cater for the family's nutritional needs. We had an elderly lady, the grandmother. She was 67 years old, came through malnourished, and with the prepackaged food, it was really difficult for her to digest, and she became unwell until I could actually get access to the supplies through community. There was initially a food shed set up where the food and the resources that went to community were only to be accessed by community, and that's for us, that's where a lot of the politics actually came into play, because we were responsible for the supported accommodation, we weren't able to freely access the food and resources within the community. And it took a lot of negotiation and conversations with the local providers, and building our partnerships from day one and strengthening those partnerships through our relationships and our connections. Next slide, please, Jen. So as you can see, this is a picture of our side office at the caravan park. Basically, we had the structure. The health staff were responsible for setting up operations. They successfully set up operations within the 2 days from when we hit the ground on the 4th. From when they hit the ground on the 4th, sorry. Yeah, so they basically had fitted out with the computers, get access, software programs to get access to the family's health records and all the logistics around that. So as you can see, we had staff were actually came together from right across New South Wales. We had amazing people with amazing skill sets. We had a nurse oncologist from Albury. We had a pediatrician that's worked at Westmead over 20 years. So we had really skilled staff on the ground level, which, really comforted the family, knowing that, we did have a pediatrician on site where he could cater to the babies and also the younger children's needs. Next slide, please, Jen. As you can see, we did actually 2 health checks a day, morning and evening, for me to ensure that my family at the supported accommodation felt culturally safe. Initially, actually met with them and greeted them when they first arrived on site. Assisted the police in delivering New South Wales health orders as well to the individual members of the families. So police came on site every day to deliver their orders, and also, as I said, assisting the staff regularly with the morning and evening checks, ensuring that the families felt safe and supported. And I guess even though it was only twice a day, a lot of my interaction with the families actually were throughout the whole day. So it was just constantly yarning with them, identifying, what their barriers were, what the issues were, and working together to meet those needs. Next slide, please, Jen. I've just put a basic brief matrix together just to explain the importance of having Aboriginal health workers or Aboriginal people on site, or in community, working holistically with health staff and local health district at a local health district level in Wilcannia. And as I mentioned before, the strengths that us Aboriginal health workers bring to the brought to Wilcannia was, our connections with mob, as I explained before. It's making that initial connection straight up. Who's your mob? Where you're from? That's where we build connection, develop our relationships and our trust, and we then become a knowledge translator between the families, staff, and to community to access whatever supplies or the families were needing at the time, ensuring that the information that they were receiving was culturally appropriate and the families could understand that. This, with my engagement, it actually showed the family was actually seeing that I was working alongside our health staff and ensuring that there was a honesty and transparency, and they could see that I was actually being consulted, on all levels before conversations or after communicating with the families. Staff are really really good in allowing flexibility to ensure the families felt culturally safe and supported. This was easy then for them to establish relationships and build trust with the family. This didn't happen overnight. It was a continuous conversations every day, even just delivery of resources that came in that the family needed, food, toilet paper, whatever the family was needing. It was actually, getting the staff to actually take the supplies over to the family, just to have a yarn, build the connections and rapport. Also, the importance of local community partnerships were vital for us working in community out of Wilcannia, and also knowing the politics around that. As I said before, we went in blind. We didn't know what was going into. It was actually always constantly doing a 360, ears on the ground, finding out, what was happening in community. So I was able to then access the food and daily supplies and to be able to cater for the family's needs, and also the social emotional well-being, being that they originally went up there to bury a loved one, and then the outbreak occurred back in July. So this family was stuck out there that time and hadn't put their loved one to rest. So there was a lot of trauma that the families were going through at the time. It's just being mindful and ensuring that they were also supported emotionally as well. It was just having those cultural conversations around, their religion. Aunt reached out to speak to an Aboriginal minister. So, it's looking at all those determinants. Okay, I've got to find an Aboriginal minister. So did that. The bishop was on side. I had, he came down and actually played his bagpipes down there just to provide some entertainment. He was also delivering food parcels and any supplies that we needed. So it was just tapping into our connections to be able to meet the needs of the families. And as I said, they went up there to bury a loved one and got stuck there and eventually all became positive. And at the end of it, on the 24th was actually 24th of September was when they buried their loved one. And it was just how because so positive, was actually looking at how can they still be able to participate even though they're positive. So I was actually having conversations with the funeral director and having the hearse talking to him about having the hearse available to drive through the supported accommodation down the caravan park, and for the hearse to be able to stop in front of each of the vans. So there was 6 that was actually being utilised, and the hearse actually stopped at the vans, so the families with the windows open, so the family could actually, have their farewells and be able to participate in the burial as well. So it was a lot of, for me, there was a lot of politics at play. Is actually, and you know, it's just being mindful of that on a high level as well. So as I mentioned, you know, constantly doing 360, aware of government processes, community politics, the governance in community, and being able to meet the families' needs and ensuring that they feel safe and supported. You know, at the end of it, we had a call from the police commissioner around about 5:30 to say, you know, he approved the family to leave the caravan site and actually go into town to the cemetery and actually be able to, you know, be a part of the ceremony and be with their loved ones, ensuring that, you know, we had to social distance. The families were given PPE to put on, and they were, as I said, you know, they were there with their loved ones at the end of the day, which made the transition a lot easier than if they weren't able to participate in the funeral at all, and was very traumatic time for the family. But being able to take them out and escort them out to the cemetery and for them to participate, it's, you know, it's ensuring that you know, that was a really significant time of their well-being, grief and loss, and being able to grieve with all their family members. The difficult part was actually donning on and donning off at night time as well. So yeah, we constantly had to be, you know, be adaptable, working in a rural and remote outback communities, and as Krista mentioned before, you know, the donning on, donning off, and ensuring that it's as I said, at night time was the most difficult time for me, was at the cemetery when we were doing that, and ensuring the safety of ourselves and as well as the community. We then, our staff then actually went along and wiped the seats down at the cemetery. And yeah, that's pretty much from me. Thanks, everyone. Thanks, Jen.
Thanks so much.
Hey, Jen, did you want to go to the next slide?
Oh, yes, definitely. Can you still see my screen?
Yep.
Okay, so is there anything else?
I'm not too sure if it's my laptop because I'm just at a vaccination clinic. So has it come up a slideshow with just the Wilcannia's last active case was 25 days ago, so they've had a total of 152 active. No, this is all, that's it. So I guess just the final words is Wilcannia's been 2 weeks COVID free now, and it's just a massive, huge achievement for the community in the Barkindji mob.
Thanks so much, girls.
Not too sure if it's my...
That really is a great outcome, and thank you very much for presenting. We might just have a quick look. There's a couple of questions that have come in. So I'm just going to stop sharing my screen, and if all the presenters could turn their cameras back on, that would be great. We've just gone a little bit over time, but we'll only be a few more minutes. How is an AMS notified of a positive case in the community?
So I can take this, and then the cultural support group might add as well. We ask in our case interviews that people notify their GP or their normal service that they're linked with, just in case sometimes they might want to do a telehealth appointment with that GP or their normal health service. So we encourage people to let their GP know.
Okay, great. Can we have access to vaccination rates of our communities by health area? Example, Tablelands, Peel, or by postcode or council areas, to assist us where to give targeted effort, like organising vaccination clinics to the areas and investigating other barriers?
Yeah, that information's actually already available. It's a little delayed and a little behind, and it comes from a couple of different data sources that don't always match up. But we do actually have an Aboriginal Vaccination Steering Committee that Patrick Cashman and Sharon Tyder co-chair. So I think if whoever that person who asked that question was, if they can direct, direct that inquiry to Sharon and Patty, they have better access to the data, and they're able to have that one-on-one conversation. And mapping's already been done right across HNE. I'm not sure, I can't speak on behalf of other LHDs, but yeah, they're mapping all the gaps now and planning pop-up outreach, at home testing. Yeah, so we're actually just had a meeting this morning about that. So that's currently underway.
And there's quite a few comments just saying thank you for your amazing talk, and everybody's clapping, so thanks girls. Just one more question's come through. How do you coordinate with your local AMS?
Well, we've had a cultural governance group going since March last year when the outbreak first started, and we started to plan for that. So within the Aboriginal public health team, there's three main parts of what our role is. So we embedded a team within the ICS structure. We coordinate the cultural support, which is what Katie's leading, and we also have the cultural governance group on COVID-19, and that's made up of about 25 key stakeholders and partners, and all of the AMSs are participants on that group. Actually, they're our main partner on that group, and then it's also made up of Land Councils, Department of Education, DCJ, community-controlled organisations, the community-controlled preschools, and any other people from Department of Aboriginal Affairs, National Indigenous Agency for Aboriginal People. Yeah, we have a broad network there of different people, but our main partner is the AMSs, and we meet with them regularly about COVID and the outbreaks. If there's a local case, we're talking to them all the time about how we can support them. They're also talking to us about how they can, do things on their end, and also yeah, just maintaining that regular contact through that group or through the vaccination planning meetings. Yeah, there's lots of opportunities for that to happen. And if that's not happening enough at your AMS and you're in Hunter, New England, then please reach out and let us know. And if you're in another LHD, then reach out to the public health unit and tell them they need to be making those connections with the AMSs.
Thanks very much, everyone. One more comment come through. Thank you for the presentation. It was really good to hear all of your hard work and what helped the communities. Well done, everyone. Thanks so much, girls. There will be a copy of this webinar available on our website, and a link will be sent through in the confirmation email. Well, thank you, and we'll catch you next time.
Thanks, Jen. Thanks, girls.
Thanks, Jen.
Thank you. Thanks, everybody. Stay safe.